Good afternoon and a warm welcome to the season finale of the 4th edition of Let's Talk Primary Healthcare talk show. I'm Jamina Ilgiziakova, policy analyst for the WHO European Center for Primary Healthcare, and we're co-hosting this episode today with my colleague Arnoldas.
Good morning, good afternoon. We most welcome for joining this our session. I'm Arnoldas Jurgutis, Technical Officer of WHO European Center for Primary Healthcare, and we are so excited that you're joining this webinar.
This season, we discussed a variety of topics on primary healthcare in our region. Most recently, we talked about vaccine hesitancy and how PHC can address that, how to cover access gap for rural and remote areas, and many other topics. You can rewatch the recordings on our YouTube channels, and my colleagues will be sharing them in chat. And what is the topic for today? It's one of the most burning topics in primary healthcare. It's implementation and the strategies to achieve it. Even when there is a high political commitment and legislation in place, sometimes strategies remain on paper. What are the bottlenecks that prevent to realize the implementation, to realize the vision in practice, and what solutions can we implement to achieve them?
Exactly. We all know that already 45 years since 1978, since Almaty Declaration, we know a lot of deal about primary healthcare role. And we have famous global strategy, the latest one, Astana Declaration, supported with a lot of WHO technical policy papers. We have national strategies, but does we often implement these strategies in the practice? Does we always see the sustainable implementation? So that is, during 1 hour of these panel discussions, we are here to learn from panelists what is really these barriers for implementations and ways, success factors for implementations. So with this background, also in addition to this 1 hour panel, you will have opportunity to tell your country experiences in 2 deep dive sessions, which will be parallel session, one in English and one in Russian language. And also, please use actively during this panel discussion chat, where you will find a lot of shared links to the documents. So with this big background, for me is big honor to turn to this really very experienced panel who connects policymakers, global policymakers, implementers at practice level, and introduce Faraz Khalid, Research and Innovation Officer in a special program for primary healthcare at WHO headquarters. Alisa Nismane Aishpura, family doctor and president of Latvian Family Doctor Association.
And Nacho Shingelia, family doctor from Georgia, 2024 5-star doctor awardee by Wonka Europe. And last but not least, Simon Dries, a policy officer from DG Reform European Commission. And let's dive right into the first round. Simon, let's start with you. You're an implementer of primary healthcare strategies as well as healthcare strengthening strategies by European Commission. And what, in your experience, have been the bottlenecks and the challenges in implementing these reforms?
Thank you very much, Jamin and Arnoldas, for the invitation, and very excited to be here and also learn from the colleagues. So indeed, as you said, I work for a department of the Commission that supports member states with technical assistance, and we have worked a lot on primary healthcare, myself in Austria, Slovakia, and Estonia, but we've also had projects in other countries, in Belgium and also in Spain. And I think the implementation barriers are really very similar across the board. So we have worked a lot on improving coordination and collaboration, and also moving to more multidisciplinary teams working together to provide primary healthcare. And a lot of the barriers have come from resistance to change overall, from the resistance to any loss of power, basically. family. Whenever we talk about incorporating more different categories of healthcare professionals, I think there are concerns both from the practitioner side of who is the ultimate guide of the patient, who is the main responsible person for guiding the patient through the system. But there are also concerns about losing out in terms of power of certain stakeholder groups, financial shifts that then also cause opposition from stakeholder groups. So I think these are very common concerns across the board. I think also from patients, we have concerns that are voiced. For example, when there's a lack of trust in primary care, and patients really want to have access to specialist care without any sort of gatekeeping or any other requirements that they have to follow. So I think we see a lot of different barriers from the different stakeholder groups.
Thank you so much for these insightful points. I really appreciated your point about the sort of political contestation about loss of power and loss of influence, and how challenging it makes it, the implementation in practice. Dear Arnoldas, I would like to turn to you, actually. Before joining WHO, you were an implementer as a family doctor, as a manager, as someone who participated in ministerial technical working groups, and now you're supporting countries in their implementation journey. I'd like to pose a question to you. What, in your experience, have been some of the big challenges when implementing primary healthcare vision in practice?
Thank you, Jamin, for this question. Yes, more than 2 decades ago, really, I was in innovative practice, surrounded by really great enthusiasts who just graduated family medicine residency. They had new attitudes towards person-centered care, wider scope of services, and we were happy to see our results, our achievements. We were happy to see our patients who were more satisfied and less hospitalized, but there was not in place performance monitoring framework, and no one measured at national level these results. Of course, we were good in often supported by international partners and communicated our achievements to policymakers and so, but our communication channels were not as strong as channels of communication of narrow specialists. And exactly like Simon said, they also connected with beneficiary politics. The patients wanted to get access to the specialized services, and they communicated that there is no results countrywide because they haven't seen these islands, results from these small islands. And finally, there was no finalization of the design of primary healthcare model, and were no rollout of this model. In opposite, it was rolled back of that and stop of primary healthcare implementation for several years. So that was few decades ago. So what happens now? Let's turn now to our panel again, and now I invite Nato. You are, congratulations for this high Wonk Award as a 5-star family doctor. So what challenges in Georgia you face when you implementing your ideas, your policy recommendations into practice? Nato?
Thank you so much, dear Arnoldas, for your congratulations and for your kind words. It was a really great recognition, not only just for me, but also for our Georgian Family Medicine Associations, and I'm really grateful for everyone who contributed in this great reward. And thank you so much for this opportunity to participate in this great talk show about the problems of implementation of primary healthcare reform. And as for your question, Arnoldas, yes, of course, Georgia is not exception from other countries. And of course, when we are trying to implement different reforms and different projects, we are always supported with international donors, with our family medicine associations, but of course we met different challenges and barriers while implementing those new reforms and changes in place. So what were those challenges? I think that the most important challenge which we had there, it was some organizational cultural shift, which is very important because you know that we are trying to shift this culture from the reactive model, which was mostly oriented to the medical care, when the patient was going only for some medical problem and the doctors were providing there only for that medical problem, to the proactive care. Just active finding of the new cases, screening, prevention, active preventive activities. And this was really very difficult because this required the changing of mindset and organizational culture in the primary healthcare facilities. Of course, there were different challenges as well, like, for example, the resistance from the primary healthcare staff, because uncertainty about the new model of the care. They were very comfortable with the model, with the old model, and they didn't know how the new model will impact their new practice. So, for example, will it increase their workload? So they were not certain about the ability, for example, how they can manage implementation of the electronic medical record system, and etc. And there was the resistance, of course, of the primary healthcare facilities. So another challenge which we face in Georgia, this is the shortage of the workforce, primary healthcare facilities, because, for example, we have the shortage of the nursing staff, and also we have the aging staff in primary healthcare, because more than 50% of the primary healthcare professionals are over 50 years old. We have the limited resources in place because they have very, very busy workload, and this leaves no time for additional training, additional educational activities. And of course, this is the challenge. Geographical challenge as well, because remote areas, for example, the villages which are remotely, it makes very difficult to make some supporting activities and training activities in those geographical areas as well. And also there was the lack and gap in knowledge, because during these recent years, during the last 2 years, we made a lot of new protocols, new updates, clinical pathways, but there was not implementation of those clinical pathways throughout Georgia, and it was the gap in the knowledge of new evidence-based recommendations, how to manage different chronic conditions and different problems in place. So I think these are just some list of those problems which we faced during implementation of different projects, and I think that they are similar to other countries, but also with some peculiarities for Georgia as well. Yes.
Thank you, Nato. Thank you, Nato. Great examples how really you have to address this rooted both into provider society and the patients population society proactive approach, reactive approach, that I coming to the doctor only when it's a big problem. I don't go for prevention. And you really have to work with that. And also how to change and how leadership you have to change attitudes of doctors who are unhappy maybe with this situation, what is now, but they know what is reality now, and picture for the future is not so clear. So really, so now let's turn from practice and leadership in Georgia from NATO to Alisa, to you in Latvia. So what key challenges in Latvia was for Latvian primary healthcare professional leaders to translate their ideas into policies and to practices?
Thank you, Arnoldas, for inviting me to explore and share our experience in our country. So I decided to speak about maybe very recent problem and solution what we got. So to be more effective in providing proactive primary health care, we realized that we don't have enough time for all tasks we could and would like to provide for our patients. So the biggest challenge was that having an additional non-medical staff initially wasn't unanimously agreed upon by fellow doctors, and policymakers also had doubts. So we had to speak with our colleagues about that. It would be very helpful that we will have one more employee in our practices who might be not medical personnel. And not all of us was with this opinion agreed. And after that, after our discussions, we had to go to our policymakers to tell them our opinion.
Yes. Okay. Okay. Thank you, Elisa. It's really sometimes challenging also to implement these innovative solutions. And Jamin?
But there have been some research initiatives to shed the light on what are the barriers and the drivers to successful primary healthcare implementation. Dear Faraz, you've spearheaded such initiatives, particularly on the roles and positions of different stakeholders towards the primary healthcare implementation and primary healthcare oriented reforms. Could you please give us an overview? What have been your insights from this research?
Sure, Zameen and Arnoldas. So let me first get my slides projected. All right, can you see my slides in the slideshow mode?
Yes.
All right. By the way, for the audience, these are only 2 slides. Don't worry. We will keep the spirit of a talk show. So what I'm sharing with you today in all my interventions is based on the initiative which we have been undertaking here in WHO headquarters in collaboration with our 6 regional offices, 9 country offices, but also a very good collaboration with colleagues from Howard University. So like what we heard from our colleagues earlier, we can already sense that the challenges they are citing, they are not only technical. We already sense that there are tensions between different stakeholders as they undergo the reform process. And these tensions, they come from different perspectives. And hence, to better understand and unpack this subject of implementation solutions or implementation pathways for PHC-oriented reforms, we have undertaken this political economy analysis in 9 countries which have made more progress around primary healthcare reforms. So first, why we have undertaken this? When we say that reorienting a health system towards primary healthcare requires not only well-thought technical solution, but also better understanding of the politics of the process. What do we mean by that? And let me say in very simple terms, because as we see that PHC reforms, specifically when we talk about reorienting a health system, inherently they mean redistribution of resources. For example, in many of the PHC-oriented reforms across the globe, we are seeing a reallocation of financial and human resources from specialized settings to primary care settings. They may also involve redefining the roles where community health workers or nurses, they may be assuming the roles which have been traditionally taken by physicians. But also these reforms, they involve different aspects, functions of the health system. Let's say the way health is financed, the level at which services are being delivered, the way providers are being paid, the way health is being governed through the decentralized systems. So these realities go on to say that PHC reforms, they involve different stakeholder groups and fundamentally a redistribution of resources. So when we undertake a political economy analysis, in very simple terms, it's important to understand what does it mean. It means an analysis of interaction of political economic processes in a society, the distribution of power and wealth between different groups and individuals, and the processes that create, sustain, and transform these relationships over the time. And what we have seen across the 9 countries, broadly 6 types of politics interplaying with these PHC-oriented reforms. First, when we talk about interest group politics, they mean that how do different health provider associations, physician groups, health worker unions, industry groups, may it be hospitals, pharmaceutical companies, insurers, employer groups, and consumer organizations, and along the reform, what positions do they take? Either they support the reform, they stay neutral, or they oppose them. And on that, something which becomes very important is leadership politics, where commitment of leaders, they can make or break the situation. And it is not only the executive branch of the country, which is usually prime ministers, ministers of health, chief ministers, but also the legislative branch of the country, that through legislation, whether they again they support or oppose that reform process. But as these different stakeholders stake their positions, the importance of budget allocation and expenditure mechanisms, they also take importance, and their impact on policy implementation. On that, we have found that there usually tensions exist between different levels of government and different ministries for budgets. And there could be quote unquote competition while securing budgets. But also we understand that bureaucracy in many countries have an important role. And this inter and intra-agency tensions between different authorities, interest groups, and again, between different personnel who exercise influence. And not forgetting the behaviors, preferences, and political activities of the end users of the system, where it comes beneficiary politics. And then also it is underpinned by the ideas and ideologies of the users, of the consumers, of the people, and how the reform aligns with national values, with identities, worldviews, and role of the public opinion. But not forgetting, lastly, in many countries, the role of funds and ideas which support or oppose the reforms which come from external sources, and how they influence the policy decisions. And within that, the role of bilateral, multilateral agencies, international financing institutes, non-state actors, and lately we have seen a big role being played by NGOs, foundations, and different private funds. So with that, I think I'll have tried to capture that how do different stakeholders, they take positions while these reforms are undergo, and we need to understand the politics of implementation pathways as we unpack the reform process. I give it back to you, Arnoldos and Zameen, for now.
Thank you so much for this overview of political economy factors. I think it's so insightful. It's in such a useful lens and frame to think about how politics and how political economy factors affect implementation of primary healthcare-oriented reforms, which is a political process in itself. And I think our audience could relate to a lot of these.
Well, indeed. We heard in this first round a lot of challenges faced in countries presented by panelists. And also for us, thank you for framing this and presenting this political economy analysis framework where we understand how we manage these interest groups and how much still we have to systematize that our implementation solutions. So now I think audience is really eager to learn more how these countries in Georgia, in Latvia, and also in European Commission's projects implemented, and what solutions, what implementation solutions they had to manage this political economy dynamics. So, Elisa, let's start this time from you. What you can share from Latvian experience, how you managed and how you made this implementation happens, what solutions helped?
Thank you. As I mentioned before, we had discussions amongst ourselves, family doctors, leading family doctors in our association, about this non-medical stuff in our practices. So when we had these discussions, we agreed that it is very necessary possibility for our colleagues, especially for bigger practices with bigger amount of patient. So after that, we had tough conversation with the Ministry of Health. At the time, we also offered to make a work group for policymakers and doctors together. The health minister agreed to it and created said work group. In discussions, it was helpful to have that we had the patient's point of view, that they wanting to have proactive and more available family doctor services, that we had evidence-based arguments about the facts that quality criteria and cancer screening results were better in practices with a bigger amount of employees. And we had very good experience at the time of COVID-19 epidemic with gaining additional employee and family doctors' practices to go for vaccination and to help structure this vaccination work. So these are our bigger points, how we get possible that our policy makers agreed that we now have this possibility to house our third or second employee in our practices.
Congratulations, Alisa, for this, and I think audience is really excited to hear this implementation pathways you presented to achieve what you wanted.
Thank you. And dear NATO, you've presented multiple barriers in implementation pathway towards PHC transformation. What has been your solutions? What did you do? How did you navigate this challenging context?
Thank you so much once more for the opportunity to speak about this. Thank you, Faraz, for sharing great slides. And by the way, when you were presenting those slides and all of those politics, which are so important regarding the stakeholders, different politics and political economic factors, I think that they were very familiar to me when I'm thinking now about those projects which we implemented successfully in Georgia, like, for example, Caritas Czech Republic project of supporting primary healthcare in Georgia in rural areas, also UNICEF and GFMA, Georgian Family Medicine Association telemedicine project. So what are the solutions? When I'm thinking now about this, leadership politics was very, very important for us because, for example, we involved the country recognized leaders in primary healthcare practice, which was very important and motivational for that staff to implement these new solutions. So what was the motivation for those PHC personnel, PHC leaders? So I think that for them, shaping the reform and leaving long-lasting impact of this reform was the motivation for them. And also learning through the implementation of this reform was very motivational for them, of course. So one of the most important things which we tried also when we were implementing these changes, it was creating not just punishing or authoritative and talk-to-down approach, but supportive approach. It was environment which wasn't punishing, it wasn't scrutinizing, but it was supportive environment in which the people were engaged and in which people were involved and everyone had their word there to say what to say. So for example, when we presented for them how clinical audit could be conducted for different chronic conditions or for example, developmental screening of 0-6 child development, we agreed coordinated these indicators with the primary healthcare providers, and it was feasible for them. It was acceptable for them, and it was very important. We used this supportive supervision technique, this model, and we didn't just play and presented just the presentations or lectures like the monologue, but it was the interactive training which was based on their needs assessment, like using different case studies, using different challenging cases, role plays, and etc. And it was really very important because the training was based on the needs assessment. Also, it's very important that we use and demonstrating the long-term savings, like how improving the quality of primary health care can show them the long-term savings. So, for example, reducing the hospitalizations, reducing that non-necessary referrals to the specialist or non-necessary laboratory investigations and etc. can reduce the costs. And it was very motivational for them. I have already mentioned that for them it was not uncertain. So, for example, how the new model will influence and impact their routine, their everyday routine and their old model. But when they show and saw that it was very helpful for them, very useful for them. And also we, of course, for example, Faraz mentioned the beneficiary politics, and it was very important to understand the expectations of the patients, to understand what were their expectations, and through the nurses who were very closer to the patients, we understood what were their needs, what were their expectations from the healthcare, what were their healthcare seeking behaviors. And we tried to adjust our trainings, our supportive supervisions to address also healthcare needs of the patients. And it was also very important. And as I already told you, we tried, and it was possible to create the environment of the monitoring and evaluation of the changes which we have implemented with the clinical audit system. And this clinical audit was not just the tool by which they could recognize the gaps in the quality of the medical care provided to the patients, but they had the possibility to compare their standard of care with others and to see how this proactive care, how this shift-taking organizational culture will improve their care compared to others. Yeah, and this was a very big motivation for them. So I think this addressing those politics which Faraz mentioned, like leadership politics, beneficiary politics, stakeholder politics, were the ways and the pathways how we could achieve those success and how we could manage implementation of all of those things which we were able to implement.
Wow. Thank you so much for this example. I think a theoretical framework that was provided by Faraz really got anchored by this example that you've just provided. And yeah, it's amazing. It's amazing and congratulations on all these changes. Dear Simon, let's turn to you. You're navigating a complex political context of overlooking the entire region. And what were your solutions in navigating these challenges?
Yes, thank you. So I think I would echo that this framework, I think, is very helpful for our work as well. And I'll try to give some examples that fit with the different kinds of politics that Faraz outlined. So, I think if I think about the project that we are currently doing in Estonia, one important baseline, of course, is if there is really good agreement on strengthening primary healthcare in general, right? So, if basically there's good consensus really among all the stakeholders, then that is a very good base to build on. And I think that's really what has to be established first. And in Estonia, I think that really is an enabler that allows us to talk about really fairly technical issues. And those technical issues are still politically contested, but we are kind of one step further in the process, which I think really helps. I think in many countries, what we see is that what we can bring to the table is to take a more holistic approach, because we often see that there are very specific policy proposals, like introducing a new profession or doing certain task shifting interventions. And then we very often bring this perspective of zooming out. So, it's good to have this vision and this idea for reform. And it's important to have the right regulatory framework. But then we also always bring in, we have to think about the infrastructure. We have to think about the workforce training pipeline. We have to think about competencies, and we have to zoom out, not just to look at the whole sector, but also across time. So if we talk about changing really how service is provided, then we also have to think about our training pipeline and how long does it take to train new professionals and for them to really be in place, because that often is something very basic that gets forgotten, that it takes a long time, for example, to train a new family doctor or general practitioner. I think what also helps when we talk about these interest group and distributional politics, I think, is to look at, what are the stakeholder groups that are allies and that are maybe supportive, and to look a bit deeper, because I talked about in the beginning about certain stakeholders that might be opposed to reforms, but very often we find, for example, in our projects in Austria, that there are younger family doctors that come in that have very different expectations of the workplace, that are very aligned with what the ministry wants. So we have kind of a merging or a point where the top-down vision of what should happen and the bottom-up needs of the healthcare professionals actually do meet when it comes to, for example, having a more flexible work environment, more teamwork, better working conditions, or for example, new general practitioners that are not interested anymore in having a single practice, where they are also basically a business owner that has to manage other aspects that are not related to clinical work and engagement with patients. So I think these are enablers where we can find this alignment between, as I said, the top-down vision and the goals and the bottom-up expectations, which in the end helps to implement the reform. And then I think lastly, what of course we always bring is to bring in the international experience. I mean, that's why countries come to us for support, and we bring that in, and also our technical support provider brings that in. And I think this can be a very good enabler as well. So because I think there's evidence and there's good practice that can be transferred. There also we always have to look at examples that are really applicable. So similarly structured health systems, but also culturally, historically looking at similar countries. So just to give you one example, Slovakia always, of course, looks at the Czech Republic, for example, as a neighboring country. So that is also an important factor. Like, what are authoritative examples that have trust among the stakeholders that are seen as really relevant for the country?
Thank you so much for bringing up these points. And I think a lot of you have mentioned this point of trust from the populations towards primary healthcare, trust towards policymakers that these changes will be efficient and cost-effective, and trust among different stakeholders within medical society towards each other, and then that the perceived loss of power will actually result in better population health outcomes and things like this. Arnold, it's over to you.
Thank you. And now, before I turning Faraz to you with this last question in this second round, where you will share implementation solutions project and what was achieved and find out from other countries, I want to inform audience that Jamin and myself, we are very proud that we can contribute to this project and finalizing report on Kazakhstan, which was selected as one country from WHO European region where we did this implementation solution project. And I saw in your enthusiasm when NATO was talking about this organizational culture, how that is important, that we found in Kazakhstan case that changes of organization, distributed leadership, and this bottom-up innovations, openness for that is one of key factors for the success. And in addition, despite oppositions, a very nice dynamic was when leaders in primary healthcare implementation went outside medical society and sold interest in primary healthcare reforms for higher level of government to prime minister level, who understood that, okay, yes, primary healthcare really can contribute to higher society development goals like equity, social cohesion, well-being. So this support came quite strong, and finally we have like beneficiary politics who now informing ACIMATs, like regional governments, that okay, we were prioritizing to open access to hospitals because patients will be happy with who demanding these services. But now they understood that okay, all people will be happy with primary health care stronger, including these patients who demand hospital care. So this dynamics is, and what we opened is really very interesting. So for us, question to you, you leaded this project, and from New Zealand, Kenya, and all 10 countries engaged, including Kazakhstan. What, in addition, what's said today, what you can share on successful implementation solutions for primary care reforms? For us?
Can you hear me now?
Yes.
Okay, sure. So before I share some of the couple of themes which are emerging from these country case studies, especially where the reforms have been a bit successful, I want to make 2 points here. One is that when we talk about different types of politics, and 6 of them I presented here, none of them in real world operates in isolation, or they're mutually exclusive. They're in real world, they're very much interlinked. And I think from our earlier participants, when they were sharing their stories, it comes very organically clear that how these different politics in real world, they're interlinked. So they don't operate in isolation. That's one. And second point here is that, whenever we talk about politics or we talk about political economy analysis, usually it is considered that we're only talking about challenges, issues, problems, right? So when the advantage of political economy analysis that it also helps us identify opportunities. And this is where I want to draw my point that one of the common theme which is emerging from relatively successful cases is that reformers have been able to take advantage from the windows of opportunity, political windows of opportunity, inside and outside the health sector. I give an example of New Zealand, where how there was a change happening outside the health sector, broader political changes, how it helped the PHC orientation agenda, where in New Zealand there were broader electoral reforms, where there were electoral laws which empowered Maori voters, which led to new political parties emerging and gaining power in the parliament and in the government. And this in turn played a major role in health reforms which focused on equity. And equity, as Arnoldas was saying, is something and an important value of PHC. So those broader electoral changes, they really helped the PHC agenda, and they were happening outside the health sector. Similarly, as we see in case of Uruguay and Thailand, where again, elections created broader political realignment, which opened for PHC-aligned UHC reforms. So let's say in case of Uruguay, the election of Frente Amplio opened the door for PHC-oriented reforms. In Thailand, Thaksin Thinvarsar's victory have brought reformist health advocates and given them an opportunity to set the policy agenda. And they skillfully leveraged this opening to focus on UHC reforms, which are more PHC oriented. Similarly, like Arnoldas was saying, in Kazakhstan, due to political changes post-independence, PHC was seen as moving away from the Semashko model, and health reforms became a political priority. So these political ideological changes at higher level, together with sustained dynamic leadership, they have been helping drive implementation of such reforms. So with given the little time we have, Arnoldas, I stop here. My key message for this part was be aware of political changes happening within and outside health sector, and reformers have been making good use of them. Back to you.
Fantastic. Thank you, dear Faraz. It's really, I think, this message is very powerful to our audience and we also really looking forward for publication of this country cases on implementation solutions.
Thank you for this invigorating discussion. I think our audience could relate to a lot of the challenges that you've mentioned, but also I think they're left with hope that there are also political economy solutions that they can use to implement the strategies and move forward. Let's move towards the final round of our discussion. It will be a rapid fire discussion, so be ready. And we're going to talk about your key messages, key takeaway messages to policymakers, to implementing teams, to other PHC stakeholders in country. If you wanted to address them now, what would you say? Let's start with Nato.
Thank you so much. Thank you so much for this great discussion, for great examples which you have provided about the implementing solutions. So what will be the key message from me from Georgia? I think that regarding the implementation of the successful primary healthcare solutions, it's very important, first of all, of course, the political will from the government. We have this will in Georgia because we have announced primary healthcare reform, we have the roadmap. But at the same time, to implement this reform in the places, it's very important to address the needs all of those stakeholders and all of those political economy factors which were mentioned here, like engaging key stakeholders in reforms. It's very, very important. Also provide clear communication to everyone. So what we are doing and provide clear communication, what will be like the future And to show everyone the benefit of the primary healthcare reform, it's very important. Use data to drive the reform and to drive the changes. It's also very important to show the primary healthcare professionals how this will save the costings and how this will be useful for them, to address the beneficiary needs as well, to address the patient's expectations, to address their health seeking behaviors is also very important. And also, it's very important to foster positive organizational culture, to create this positive organizational culture which is supportive, which is oriented to the proactive care rather than the reactive care is very important. So I think these are the solutions which will help us. Of course, there is no 100% recipe, but those are the solutions which will help us to implement the primary healthcare reform successfully. Yes.
Thank you very much. Leonardos?
Yes, thank you. And Simon, you were presented really nice ideas, and you are talking on European Commission, great project implemented. So what would be your takeaway messages on how we could support better policies and implementation teams for primary healthcare reforms?
Yeah, thank you. I think very good points by NATO, so tough to add, but I think that really the political momentum, the pressures that we are all having to deal with kind of reinforce the need really to strengthen primary care. I think that's a message that can be used, right? Also to convince policymakers. I think the workforce challenges that we see really across the European Union, but also the fiscal constraints that health systems face, add important arguments that we really must shift care closer to the community, and that can be an enabling narrative, I think. I think we also need to be very mindful that we need a lot of patience and resilience, because a lot of this, as we have heard today, is really about culture change, and that takes a while. It takes a while to change provider behavior and to convince people that really this is the way to go. So a lot of patience and resilience. I mentioned the holistic approach to planning earlier. I think I attach a lot of importance to that. Think also about medical education. Think about the competencies that graduates must have, and how you set up your training of healthcare professionals in general. If you want to, for example, incentivize more collaboration, then that also needs to happen already at that level. I think we can add a lot from our side in terms of international expertise. So that would also be, use the international enablers. I mean, I would say, to those watch the previous episodes of this talk show, and use the resources of WHO, and come to us if you're a European Union member state, and ask for technical assistance, because we can also help a lot as an external entity, as a trustworthy enabler, and that can help as well in the domestic context. And then really my message also that I mentioned earlier about looking within the stakeholder groups, so not viewing stakeholder groups as uniform, but really looking at the differences that are very often about age, or they're about the geographical structure, and not just put stakeholder groups in a box, but look for the allies that are always there. And then I would say follow the money, because in the end the money is what has a huge impact on behavior as well, so that you make sure that the incentives are aligned in the way that they should be. Those would be my short messages. There would be lots more to say, but we are out of time, I'm afraid.
Thank you very much, Simon. And let's move to Latvia. Alisa, would you like to send your key takeaway message?
Almost all was said, and I agree with NATO and Simon as well. So I could add only maybe it would be best if we professionals and policymakers would cooperate, listening to each other's arguments, and keep working towards reaching the goal. So I am proud of our primary healthcare system in Latvia, and I think that it works very good, and our system is quite well organized. We have many problems as others, of course, and we have to make these changes step by step. And it is very, very important that we have this down, up, and up, down conversations. Thank you.
Thank you, Elisa. And looking for us to you, and now I imagine that this question, when I put what is takeaway messages for policymakers, you can speak for 1 hour. We still have time, but what would be, of course, this will be published implementation solutions case studies, but already now from this great material you already have, what would be like 3 priority takeaway messages, what you prioritize to tell to policymakers, implementation teams, both globally, regionally, and nationally, and also in the micro level for implementation of primary healthcare reforms?
Yeah, so again, my lens for discussion today is political economy, right? So my 3-4 key messages are again coming from that perspective. So first is, I think, as Arnoldus, you said, for across the range of people who work at different tiers, we first need to be mindful about the scope and the nature of the reform, because that also determines how much opposition we may get. So usually what we are seeing is that reforms which are more technically oriented and which do not shake the financing and or governance arrangements, they usually face less opposition. So in a way, technically oriented reforms, they face less opposition. For example, we have seen from Kenya's primary care networks and Kazakhstan's multidisciplinary teams arrangements, since they have not affected directly provider payment, so they have not faced that fierce opposition. But we know that in New Zealand, the efforts to change physician payments, that generated major opposition. And that also partially, in some instances, it was undoing the reform over the time as well. So first point here is to know the scope and the nature of the reform. Second is to be, again, mindful about the historical legacies and past dependencies of the reform process. For example, what do I mean here? In case of Thailand, we know that these financing reforms over the last at least 2.5 decades, they have been dramatic, but they have faced little opposition. Why? Because the losers within the system, within that financing shift, they have been in the public sector, and there has been a zero-sum game. And due to the long-standing investment in their district health system, in a public district health system, there have been no losers as per se. So, but we know that in case of New Zealand, this opposition was stronger from private sector GPs. So the point I'm trying to make here is that the historical legacy and path dependency, that also determines the support and opposition we may get. The third point here is, which sometimes could be very contentious, is the overall political context. And with that, the regime type. In some countries, the type of regime, there is less space for contentious politics, for protest, right? And in those quote unquote, again, I'm not saying when I say closed political systems, I mean a negative connotation, but I mean that socio-culturally, that is how the political system has evolved in that country. So there may be less opposition, but in systems, the way historically they have evolved, there are more openness to opposition, where we see with PHC-oriented reforms, there have been more and more opposition, more fierce opposition groups taking such positions. So my last point here is that, which I mentioned earlier, that for reformers, and reformers are not only at national, subnational level, each one of us is a reformer in his or her own capacity, right? So we need to be knowing and making good advantage of the windows of opportunity inside and outside the health sector. And for that, we need to be prepared to think and act politically right from the start, which could increase the likelihood of the success of the reforms. Thank you again for the opportunity. I hand over back to you, Zameen and Arnoldus.
Wow, this has been such a rich discussion. It's actually hard to summarize. I almost feel like picking up every single point that you've mentioned, all of you. And indeed, I do agree on the interplay of all the political factors, both positive and negative, as barriers and drivers for the reform, and how they descend top down from the national level, how there's a wider political context, which also could present an opportunity for the reform, and how bottom-up approaches do also exist, and there are strong voices that go up to the national level. And I did really appreciate the point about investment in time to understand that all these organizational changes, cultural changes, they take time. And usually in our roadmaps for implementation, we don't really account for that. And I really appreciated that point. And we would like to hear more. I'm sure our audience is eager to speak more on this topic. And we have deep dive sessions ensuing this discussion in English and Russian. So my colleagues will post links to that in chat. And once you after we finish this, you will receive also a survey about this episode. So we would like to hear more from you, what has been a new insight for you, and the topics that you would like to see in our next iterations of this talk show. Arnoldas, back to you.
Thank you, Jamin. It's really I'm very excited with all these discussions, and it's, as Jamin told, it's so much new messages coming that I think the best is just to emphasize that really when we're implementing, and we know technically what we have to implement, not forget about political economy and not forget about interest groups of different stakeholders, and that you always have to work on the both part, what you want to implement technically and what is political economy. And like also Simon and others emphasize that we have to be very sensitive where is really windows of opportunities and where we really can push, and where we can what technical issues is really time now to implement. And also political economy, as always, for us you emphasize, I think that is really issue which coming more and more on our work agenda. And Melita Jakob, lead of our Almaty primary healthcare team, is really now highly prioritized that we in implementation will more focus on the solutions, not only on the technical. And really we see that a lot in our countries have to be done really to finalize design and implementation of model, where it's not only technical issues, but it's overall finalization of implementation and mutual agreement, mutual stakeholder agreement on what is best. And that is a lot about political economy and a lot about communication with various stakeholders. So thank you very much to audience who joined that, and we see you sharing your experience soon in 1 minute when you connect through the links provided and Jamin informed in the chat. Thank you, panelists, really great ideas, great sharing. Thank you for your time to being this hour here, and who can please join the deep dive sessions. Thank you, Jamin, for moderating this session. It was so excited, and thank you all team who contributed to this event.